Thank our ranking member. I welcome the members in attendance. Ranking Member Grassley and members of the committee, today's hearing is about guaranteeing Medicare's solvency, a good thing to do, by balancing the tax system so that it's less rigged and more fair. Another good thing to do. So, two good things. In July, the Budget Committee held a hearing on protecting Social Security by taking away tax tricks that let those at the top pay lower tax rates than teachers and firefighters. Today, we turn to Medicare, our other pillar of American retirement security, whose insolvency is predicted to arrive sooner than Social Security's. Right now, a government shutdown looms because House Republicans are once again trying to make the tax system even less fair, to give more freebies to big business and billionaires. Republicans over there want to maintain the massive exemption for inheritances to wealthy heirs. They want to keep tax breaks for multinational corporations that send their profits and jobs offshore. And they want to hamstring the IRS from catching wealthy tax cheats. Nobody likes these policies, so they have to hold our government operations hostage. It will cost billions and add to the deficit if they succeed at shutting the government down. At the end of the day, their point is taking care of the billionaires and big corporations. The rest is smoke and mirrors. Any serious conversation about federal spending and deficits must also include Medicare. According to CBO, Medicare, along with Social Security, will make up more than half of spending growth over the next decade as America's population ages. And without new revenue, Medicare will cover less than 90% of scheduled benefits beginning as soon as 2031, only 8 years away. Since its inception, Medicare has ensured that our nation's seniors do not become impoverished due to illness. As a result, older Americans live longer, live better quality lives, and get better care in the healthcare system. Today, nearly 80% of Americans either receive direct support from Medicare or have a family member or close friend enrolled in the program. Almost every senior in this country will receive Medicare benefits, which they have earned throughout their working lives and which let them retire in health and dignity. Rhode Island seniors understand the importance of Medicare on their quality of life. Joyce from Pawtucket said, "Medicare is a lifeline for me. Reducing benefits would cause me to neglect medical problems, and I would actually end up in the hospital." Lisa from West Warwick said, "Without Medicare, I would exhaust my finances and go without care and medicines." And Anna from Providence said, "Medicare helps me in countless ways. It helps pay for my wheelchair, shower chair, lift to get in and out of bed, doctor's visits, and medicine, among other things. All of these are essential and enable me to continue living my life." But for decades, some Republicans worked publicly to undermine Medicare, to have Medicare, as former Speaker of the House Newt Gingrich put it, wither on the vine. They proposed raising the Medicare eligibility age, turning Medicare into a private voucher program, and even sunsetting Medicare altogether. Then came the State of the Union address earlier this year, when Republicans and Democrats together gave President Biden a standing ovation when he declared that cuts to Social Security and Medicare would be off the table. That bipartisan consensus, if it was real and not more smoke and mirrors, leaves only one option: raise revenue. And we can raise revenue by unrigging our tax code. We can close loopholes that allow the super wealthy to avoid taxes. It would be good to level the playing field so the wealthiest in this country can't play by a special set of rules and avoid paying a fair share. We can and must protect Medicare. We can and must do so without cutting benefits. And we can do that by making our tax code fairer. Win, win, win. According to the CMS chief actuary, the authority on Medicare solvency, my Medicare and Social Security Fair Share Act would ensure Medicare remains solvent effectively forever. And we heard at our Social Security hearing that my legislation would also extend Social Security solvency indefinitely. As I told my Republican colleagues at our Social Security hearing, I'm more than happy to welcome serious proposals to protect Social Security and Medicare without cutting benefits. I've spent enough time in the Senate to know the difference between freewheeling chat and actual proposals. Actual proposals are what lead to actual agreements. So feel free to join in with an actual proposal. My proposal ensures Medicare solvency forever. It does so by unrigging a rigged tax system, so those who can most afford to pay don't play by a different set of rules. It's available for everyone to see and debate. We face simple arithmetic: raise revenue or cut benefits. Those are the options if we are to preserve Medicare. If we abide by what seemed like a bipartisan commitment not to cut benefits, we must safeguard Medicare by raising revenue. It is literally life and death for millions of older Americans. Senator Grassley.
Thank you. Holding this very important hearing because we all recognize that Medicare as well as Social Security are very much a part of the social fabric of America, and they may be government programs, but they also interact with private sector retirement and health benefits as well. So it's not something that just government does, but private sector retirement and healthcare programs plan on interacting with it. Republicans want to preserve and strengthen this program for future generations. For decades, Medicare has provided seniors and those with disabilities access to routine life-saving care at their local hospital, doctor's office, and pharmacy. As then chairman of the Finance Committee, I'm proud to have led the effort in 2003 to modernize Medicare by establishing a prescription drug benefit. That effort required bipartisan cooperation from both chambers and presidential leadership. In the first decade of the Medicare Part D, the federal government spent 36% less than CBO projected, while still improving access to prescription drugs for millions of seniors. That law also requires the Medicare trustees to review Medicare finances annually. For the past 7 years, Medicare trustees have issued a funding warning because Medicare's outlays are expected to exceed its dedicated revenue by 45%. Medicare's hospital insurance trust fund is also in poor shape. Both CBO and the Medicare trustees expected to be insolvent in about 10 years. Upon insolvency and absent congressional action, Medicare Part A providers will see an 11% cut in reimbursements. We should be moving our healthcare system from volume to value, but we need to accurately account for what's working and not working. As I stated at our Social Security hearing, the only way to make these critical programs sustainable is to follow the Ronald Reagan Tip O'Neill model of 1983. And just as an aside, remembering some of the things you said in your opening statement, that would include more than just tax increases. That would include more than people putting proposals on the table as you're asking us to do, because I think they sat down at a table with nothing on it because they wanted everything to be negotiable, and it ended up tax increases, it ended up changes in formula, it ended up changes in retirement age, and I suppose they thought they were going to save Social Security for 20 years, but as we see now, they saved it for 50 years. And it's that bipartisanship that come between a Democrat speaker and a Republican president that we just can't let Social Security fail, that led to their success. But everything being on the table, it wasn't Republicans putting something out, Democrats putting something out, because that gives people opportunity to shoot at things. So we've got to work in a bipartisan fashion and keep a range of options on the table. Unfortunately, anytime Republicans mention Medicare being in trouble, Democrats accuse us of trying to blow up the program. And blowing up the program is a pretty rich statement, considering Democrats have proposed and enacted major cuts in Medicare, often using the program as a piggy bank to pay for unrelated spending. Obamacare cut Medicare, including an annual 1% reduction in provider payments. I don't know whether we Republicans accuse you of cutting Medicare or not, but we could have, like we get accused of proposals we put forward. Democrats have proposed cuts to Medicare Advantage, which ignores the choice and competition these plans often offer consumers. On top of these Medicare cuts, the so-called Inflation Reduction Act, passed only by Democrats and President Biden, stole budget savings from Medicare to subsidize green energy tax credits. Most of these Democrat tax benefits will go to wealthier taxpayers. And let's not forget proposals like Medicare for All that would cost $30 to $40 trillion in the first 10 years, more than twice what Medicare costs today. Under this plan, hospitals would see a 16% reduction in revenue, resulting in closures and reduced access to care. Then there's the President Biden's latest budget, which kicks the can down the road on Medicare. It forgoes real solutions in favor of accounting gimmicks, massive tax hikes, and price controls that will reduce access to life-saving drugs and treatments. The proposal currently touted by the chairman would push the top marginal tax rates above 50%, impose a 37.4% top rate on capital gains. We don't talk much about the consequences of those policy decisions, but the CMS actuary concluded the proposal would address Medicare's long-term solvency, but with the caveat that he couldn't, quote, independently assess the reasonability of the revenue estimates for the stated provisions, end of quote. Based on an analysis of the proposal by Tax Foundation, which I ask unanimous consent to put in the record, the chairman proposed capital gains tax hike is a revenue loser. Moreover, the tax hikes as a whole will cost about 700,000 jobs. These tax hikes won't just hit high-income Americans. While proponents claim only the top 2% will be affected, the proposed income thresholds not being indexed for inflation has a much broader effect than just the top 2%. As a result, the Social Security chief actuary estimates that up to 25% of the households will be captured by the end of the projection period. The truth is, taxes on the rich alone won't have saved Medicare for children and grandchildren. If Democrats believe otherwise, then request a CBO and Joint Committee on Taxation to analyze the proposals. So I think we'd like to have a more widespread investigation of these facts. Before you saw that I was through with my remarks, but I wanted to just point out something that I gave a couple weeks ago on a speech on the floor of the House, and this won't take me maybe just a couple minutes. It's obvious that our healthcare system in the United States needs reform and accountability. However, we shouldn't ruin it by turning it into a government-run healthcare system, whether you want to call it Medicare for all, single payer, or socialized medicine. I referred in my speech then to a Wall Street Journal article highlighting the failures of some government-run programs. They wrote this about Great Britain. Quote, now the state-funded service is falling apart. People who suffer heart attacks or strokes wait more than 1.5 hours on average for ambulance. Hospitals are so full, they are turning patients away. A record 7.1 million people in England, more than 1 in 10, are stuck on waiting lists for non-emergency hospital treatment like hip treatment, end of quote. The article went on to say, quote, delays in treating people are causing premature deaths of 300 to 500 people a week, and 1 in 5 British people were waiting for medical appointment or treatment at the National Health Service in December. If you didn't find that alarming, I said on the floor of the House, in May, British Columbia announced that they were sending cancer patients to Bellingham, Washington, in the United States for treatment. A Canadian news outlet wrote that Health Minister Adrian Dix announced, quote, that eligible breast and prostate cancer patients will be sent to one of the 2 clinics in Bellingham for radiation treatment. The unprecedented move to send thousands of British Columbia patients to the U.S. over the next 2 years is an attempt to address the backlog that the British Columbia has in one of the longest waits for radiation treatment in Canada. Canada is taking this action because its cancer patients face unacceptable waiting lines. When I read about Bellingham, Hampton, it reminded me of this. In the years that I've been fighting doctor-owned hospitals not having special treatment and not being, conflicts of interest and all that, I used as one of my examples that there was a Texas hospital that said, if you have an emergency, call 911. That was posted in that hospital. So here we have British Columbia posting in hospitals, if you need emergency action, go to Bellingham. And I think it's a crime that we would be thinking of things like that in America. Thank you for listening to me.
I'm always glad to listen to you, and I would simply say that I don't think we have to look as far as either British Columbia or across the Atlantic for models of how to do healthcare reform. I think the accountable care organizations from the Obamacare bill, I think the CMMI work that is going on, we have really exemplary ACOs operating in Rhode Island. I suspect you have some very good ones in Iowa as well, and I think they can lead a transition to patient-centered care and away from the fee-for-service treadmill that we have seen improve the quality of care and lower the cost per patient. So I think they're good bipartisan ways to proceed, and I look forward to working with my ranking member. With that, our first witness is Dr. Marilyn Moon, a visiting scholar at the Center for Medicare Advocacy. She is an expert on healthcare financing and delivery, with a particular emphasis on Medicare. She previously served as chair of the Maryland Healthcare Commission at the Congressional Budget Office and as a public trustee for the Social Security and Medicare trust funds. She's a member of the National Academy of Medicine and is on the board of the Medicare Rights Center. After she has made her statement, we will hear from Ms. Chai-Cheng Wang, who is Executive Director of the Tax Law Center at the New York University School of Law. Before starting the Tax Law Center, Ms. Wang was Senior Director of Economic Policy for the Center on Budget and Policy Priorities, where she worked on the analysis and design of a wide range of federal tax, fiscal, and economic policy proposals in collaboration with tax academics, practitioners, analysts, and advocates. We are also joined by Mr. James Capretta, a Senior Fellow and Milton Friedman Chair at the American Enterprise Institute. He has also served as a Senior Advisor to the Bipartisan Policy Center and previously served as an Associate Director at the Office of Management and Budget and Senior Analyst for the Senate Budget Committee and House Ways and Means Committee. I welcome you all. Your full testimony will be made a matter of record, so if you could confine yourself to the 5 minutes for your opening statements, I'd be grateful, and then we'll have a chance for the members to ask questions. Ms. Moon, you may proceed.
Thank you. Medicare represents one of our most successful federal programs, helping seniors and persons with disabilities afford mainstream medical care. Sustaining it over time deserves careful attention to protect the valuable services it provides. Since Medicare's inception, life expectancy at age 65 has risen by over 19 years as people have achieved access to life-saving care. And Medicare has substantially held down the costs of what people would otherwise pay for this care. Medicare spending per capita was over $15,700 in 2022, an amount that totals 53% of the median income of persons 65 and older. Low and moderate income persons would never be able to afford the type of mainstream care that they enjoy today if not for Medicare. While the increase in costs of the program is often cited with alarm, in many ways these costs signal Medicare's substantial success. Americans are living longer and receiving better care. Seeking ways to make the program function better and adopting new approaches to provide good care at lower cost certainly needs to be part of any discussion of Medicare's future. However, while substantial cost-cutting over the last 30 years has meant that Medicare has grown at a slower pace than private health insurance, this cost-cutting also means that Medicare has lagged behind coverage to many working Americans. Medicare is not an overly generous program, and the substantial costs of health care not covered by Medicare remain daunting for many. Excuse me. Further limitations on coverage or reductions in provider payments could leave even more beneficiaries at risk, and policy debates should keep this in mind. Indeed, there are strong arguments to be made for increasing benefits. Proposals to further cut benefits via increased premiums or cost sharing would exacerbate the inadequacy of the program. And premium support proposals and raising the age of eligibility are efforts at cost cutting that sometimes seem more benign, but can result in substantial increases in burdens on beneficiaries and increases in inequality in the access to care. Thus, rather than focusing on further belt-tightening as the means for keeping Medicare financially strong, it is important to consider additional sources of financing. Premiums and cost sharing and the impact of taxes that finance Medicare mean that many older and disabled Americans are already paying substantial shares of their incomes for the cost of their care. First, consider how much individuals pay out of pocket. A new study has found that it's over $6,500, substantially higher than what non-Medicare beneficiaries pay, and a substantial share of the resources of moderate income beneficiaries. In addition, the common view of Medicare is that younger taxpayers fund most of the program, resulting in intergenerational burdens. But in fact, beneficiaries also contribute substantially to the taxes that fund the program, and these contributions have been growing over time. After many years of Americans retiring early, more people now work past the age of 65 and contribute more to both income and payroll taxes. And the share of these taxes paid by persons over age 65 have increased. Seniors now pay about 1/3 of the income and tax revenues that go into financing Medicare. And if premiums and copays are included, seniors are responsible for 41% of the costs of the Medicare program. To ensure stable future financing for Medicare, payroll taxes and personal income taxes need to be increased potentially. Additional approaches would include expanding personal income tax revenues to funding for Part A. Alternatively, explicitly targeting those with higher incomes for revenue increases would better protect modest Medicare beneficiaries. For example, the Biden administration has proposed raising the rate that higher income persons now must pay to 5% on those with incomes above $400,000. Expanded contributions from those with higher incomes can be justified on a number of grounds. Although the cap on wages subject to tax was eliminated a number of years ago, burdens on higher income individuals are still substantially smaller than on middle income taxpayers, because higher income people receive a much greater share of their incomes from sources other than wages and salaries. A commitment to maintaining Medicare over time deserves nothing less than taking a serious look at financing issues. Thank you.
Thank you very much, Dr. Moon. Ms. Wong, please proceed.
Chairman Whitehouse, Ranking Member Grassley, and distinguished members of the committee, I'm honoured to join you today. The tax base is the foundation for the federal budget, and it supports the nation's priorities like social security, defence, education, and healthcare, including Medicare. But our federal tax base isn't broad enough to ensure the most solid financial footing for Medicare and other national priorities for generations to come. Some income from vast fortunes is completely carved out of the federal income tax base and goes untaxed over decades, lifetimes, or generations. Large multinationals can still report profits offshore so that they're subject to little or no US tax. And a raft of other loopholes and preferences shrink the tax base and attract tax avoidance and evasion instead of productive investment, innovation, and work. An example that directly hurts Medicare and the other trust funds is that gaps in the Medicare taxes mean that some high-income business owners don't have to pay into the system in the same way that workers and other business owners do, but they can instead avoid hundreds of billions in taxes. The tax base is also weakened by a stark federal tax gap. More than $500 billion of taxes owed under the law just aren't paid each year, so don't contribute to important national programs. And some $100 billion of that amount should have been paid directly into the Medicare, Social Security, and UI trust funds, but wasn't. So while I just mentioned that some business owners take advantages of loopholes in the law to avoid owing any Medicare taxes, other filers are just not paying the taxes that the law says that they do owe. Sometimes that can be because filers try to undertake aggressive but lawful tax avoidance, and in doing so step over the boundary into unlawful tax evasion. So, for example, the IRS has been taking a really close look at certain hedge fund owners and private equity managers and other wealthy business owners that they say have been unlawfully underpaying hundreds of millions of dollars in self-employment contributions each. So where do we start to broaden the federal tax base and shrink the tax gap? Here's 3 ways. The first is by rejecting proposals that are on the table right now but would increase tax cheating and shrink the tax base. That means maintaining IRS discretionary and mandatory funding, cutting the IRS budget even more deeply than agreed to in the debt ceiling deal would hurt deficits, hurt honest filers, and benefit tax cheats. It also means rejecting proposals to weaken new information reporting tools that help the IRS find and focus on tax evasion. And it means building on, rather than reversing, the corporate base broadening that was enacted in 2017. For example, the stronger limit on interest deductions claimed by large businesses should be retained. It helps reduce the tax system's tilt towards debt financing. But if lawmakers do choose to weaken some of the 2017 law's base broadeners, the cost should be offset with tax increases on corporations. Second, lawmakers can address the 3 big areas of the tax base that need attention. Income from large fortunes that never gets taxed, tax subsidies on multinationals' foreign profits, and the complex and patchy taxation of pass-through entities. A really good example of a priority in that pass-through entity area is closing those loopholes in the Medicare taxes and sending the revenues directly to the trust funds. Third, lawmakers can choose from a broad menu of other options, large and small, to broaden the tax base. One would be further strengthening the Bipartisan Corporate Transparency Act that I know many members on this committee helped to lead and secure. Stopping cryptocurrency traders from gaming the timing of their tax losses, and reducing tax non-compliance in the market for expensive art. The Tax Law Centre has proposed or analysed several dozen options to broaden the tax base, and they are linked to in my testimony. Lawmakers of both parties, including members of this committee, have often looked to base broadening as an economically sound way to raise revenues and improve the fairness and integrity of the tax system, and there continue to be really good options in this space. Lawmakers can use the revenues to protect Medicare and other federal priorities from cuts that would cause families hardship, to reduce long-term deficits, and to make new investments that would raise health and living standards and help build an economy that is dynamic, inclusive, and resilient. I would be so happy to take your questions.
Thank you very much, Ms. Wong. And now, Mr. Corpretto, the floor is yours.
Thank you, Mr. Chairman. Thank you, Ranking Member Grassley and other members of the committee. I'm very pleased to be here to have this conversation with you today. The headline focus of today's session is the impending depletion in the Medicare Hospital Insurance Trust Fund. Given the potential harm that exhaustion might cause, that is, of course, a very important matter for Congress to take up as soon as possible. But the imbalance between HI spending and outgo is actually a manifestation of a larger problem, which is the widening gap between Medicare's total costs for both HI and supplementary medical insurance to pay for both trust funds' expenses. As I show in my testimony in Figure 1, data for all of Medicare's costs and receipts from the 2023 Trustees Report shown as a percentage of gross domestic product show that there's a rapid growth in spending across the years. In 1990, total program spending equaled 1.9% of GDP. 3 decades later, it had reached 4% of GDP, and the Medicare trustees expect it will reach 4.9% of GDP in 2030 and 6% in 2050. Related to this is the very large increase in general fund transfers to Medicare over time. These are the amounts that come out of the general fund of the Treasury, uncapped and really unregulated in any way, that go into the SMI trust fund to cover any expenses not covered by premiums. This is not a well-known part of the program, but it's very important. Over the next 10 years alone, $6.6 trillion will come from the general fund of the Treasury into Medicare. By 2050, the annual transfer will equal 2.8% of GDP, up from 0.5% in 1990. So that shows you how much growth there has been in this part. For Medicare, the trend is what is most alarming. Going forward, as the population ages, the unfunded liabilities of Medicare, measured in this context, measured as any spending above and beyond the taxes and premiums collected. The Treasury Department does a calculation of this every year. It's now at about $52 trillion over the infinite horizon. Okay, it's a big number. But I think the thing to focus on is it's gone up a lot, even in the last 7 years. In 2016, it was $20 trillion less. So this number of sort of trying to assess where we're going with Medicare keeps worsening and worsening and worsening over time. And it's related to, obviously, a lot of it has to do with population aging. So there's a big challenge ahead. Just one last point on the big picture here. This is all wrapped up in a fiscal challenge that continues to worsen very rapidly and really does deserve the attention of the Congress in the near term. Right now, the deficit is scheduled to be close to $2 trillion this year. By 2050, just to put this in context, in 1980, let me go back in time, spending on Social Security and Medicare were 5.5% of GDP in total. In 2050, they're scheduled to be 13.1% of GDP. So there's just been a fundamental transformation of our fiscal situation associated largely with this. And of course, CBO projects that by 2050, mostly related to this question, federal debt is on track to go to 170% of GDP. So, you know, there's some big things ahead if some corrections aren't put in place. Now, what I recommend, I have 7, I'm going to go through them real quick in my last minute. First, I would very much recommend that this be both a revenue and a spending side of the equation discussion, and that it be bipartisan. That will bring more stability to the program over the long term if there's wide agreement about how to finance the program and try to make it as efficient as possible. Second, I would try to move toward a single insurance benefit instead of the fragmented benefit we have today. Today we have A, B, and D. It'd be better if you designed a single insurance benefit going forward, much like people experience in the non-Medicare market. I'd improve this choice structure for the beneficiaries so it's much clearer what they're picking when they sign up for their various coverage options. Today, it's a very confused and fragmented choice structure that's been set up for them. They often have to rely on brokers. I promote premium competition between the private side of Medicare, the MA plans, and the traditional program, and also competition amongst the providers in terms of the prices they're charging. Last two quickly, Mr. Chairman. I would reform the trust funds so that they are reflective of the combined program instead of having an A and B side that can add to confusion about the financing. And finally, I'd build in some automatic adjustments so that once you make a deal, that deal sticks over time through other adjustments that might be necessary to keep it always permanently stable. Thank you.
Thanks, Mr. Capretta. Ms. Wong, you mentioned in your testimony that, for instance, private equity managers can avoid paying into Medicare by structuring their income. How do they do that? What's the trick?
Yeah, so I think it's really important that the vast majority of Americans do in fact contribute to Medicare by taxes, either on income from their work or from their businesses. And the problem is that some of these wealthy filers can avoid those taxes just by using a loophole that exempts income made from various types of pass-through entities used to own businesses. And those are entities of the sort that certain hedge fund and private equity managers use. That invites hundreds of billions of dollars of wasteful tax avoidance. And as I mentioned, some of that tax avoidance gets so aggressive that it arguably becomes tax evasion because people are just not paying what they're lawfully supposed to.
It's a fairly expensive proposition to set up all those pass-through entities to enable that, so presumably we're talking about very high-income people who embark on this strategy?
Indeed, and I think the estimates are that closing this loophole would raise more than $300 billion, and some 85% of that would come from people with incomes above $1 million a year.
Mr. Capretta, you mentioned the need to revisit the taxes used to pay for Medicare and the need for new revenue. On the revenue side, what would you recommend? Your mic.
I have a little bit of a historical perspective on this, which is that when Medicare was created, it was, in a sense, an addendum to Social Security with a payroll tax. And the idea was that this was going to be, in a sense, contributions from workers at least partially paying for Medicare through their payroll tax contributions. I think breaking from that entirely and having a very different revenue stream into Medicare is possible. I'm not ruling it out.
What would you recommend, though? My time is short, so I'm trying to get.
I'd recommend
a
straight increase in the payroll tax, which would generate a fair amount of revenue.
And how about the people who are dodging the payroll tax through mechanisms like Ms. Wong just described? Should we reach out to them?
I'm not against.
You're not here to defend that behavior.
Loopholes. I'm not against changing. I think some of that to address income inequality might be best addressed outside of Medicare, but I'm not against any reasonable way to look at making sure the tax base is fair.
So you also have nice things to say about ACOs, accountable care organizations. Indeed, you recommend them as a new coverage option. I'm a big fan of ACOs because I've seen them succeed spectacularly in Rhode Island, reducing costs, sending millions of dollars back to Medicare, and causing somewhere between relief and joy through the patient population because of the new services that are enabled when doctors are freed from the fee-for-service treadmill. But what are your reasons?
Very similar to yours. I would say that Medicare would benefit greatly from a provider-run managed care plan option.
Yeah.
That there's sort of a distrust sometimes with insurance-led managed care, and a provider-led managed care option that was robust and people could opt into and not just be placed in, I think would be a benefit to the program.
Yeah, and our experience, for what it's worth, in Rhode Island has been that what's really worked has been when a primary care provider group does this on its own. The more different influences you add, the more it slows down and bogs down. But some of our best primary care providers chose early on to go this route, and they really have made us very proud. Let me put it that way. Dr. Moon, let's just say we don't get this squared away. We don't do something bipartisan. We don't do something that lowers costs and raises revenues, and we hit the 11% hit to the system from the predicted cash crunch. What does that look like to a senior?
I think it looks like pretty much disaster to a senior. A large number of moderate income seniors whose incomes are between, say, 200 and 400% of poverty simply would do without a lot of care because they could not afford additional costs that they would have to incur. The other problem is who would be providing the services if there were big cuts in payments to providers. More people might opt out of the system who are providers of care. One of the benefits of Medicare over time has been that almost all doctors and hospitals participate in the program, making it assured that people will get mainstream care when they need it. And that's something I think we do not want to even contemplate putting at risk.
Thanks very much. Senator Grassley.
Thank you.
And then just for everybody's awareness, the order after Senator Grassley is Senator Padilla, Senator Johnson, Chairman Wyden, and Senator Scott.
Mr. Caprita, I mentioned in my opening comments, and I think the chairman agrees that this has to be done in a bipartisan fashion and with a whole range of options on the table. Too often Democrats claim that Republicans want to cut Medicare every time we put or mention the troubles facing the program. So, Mr. Caprita, Democrats have a record of proposing and enacting Medicare cuts. I've already mentioned some in my statement. I'd like to have you elaborate if you agree with my statement.
Well, both parties, I would say, have sometimes put Medicare changes on the table. They have reduced spending. You can call them cuts, of course. And, you know, in the Affordable Care Act, there was a very substantial change in, particularly for inpatient hospital services, something called a productivity adjustment factor, which is still in place and permanent and has a very large cumulative effect on spending. So I think many people view it as a good thing because it's brought down hospital spending quite a bit. The question is it sustainable over the long run? We're relying very heavily on it to keep the numbers down, but the actuaries are always warning that it might be overdone.
Under Medicare for All, Mr. Caprita, what happens to provider reimbursement rates and how would that affect care, particularly in rural America?
Well, Medicare for All, I think, needs to be viewed through a political economy lens. How does it get managed over time? You know, and it's very easy to, when you're facing a budget crunch, just to pay people less. And of course, when you pay providers less, eventually there's supply changes. That means fewer providers actually provide the services at the lower rates. That's how you end up with queuing problems. So I do think that our multi-payer system, much as we dislike many aspects of it, keeps open revenue streams that makes it so that providers are not dependent on any one player to make sure they can serve patients. And so I think we shouldn't move away from that.
We always hear this business about raising taxes on the rich. During President Obama's tenure, rich was arbitrarily defined at $200,000. So as part of Obamacare, Democrats enacted 3 8/10% net investment tax at these thresholds, but didn't index them, knowing it would eventually hit middle-income taxpayers. Since this enactment, the number of taxpayers hit by this money grab have more than doubled from 3 million to 7 million. Now they're proposing to quadruple the tax and claim it'll only apply to 2% of the taxpayers. So you can understand why I'm skeptical about that statement. Mr. Caprita, much like 3 8/10% tax enacted on Obamacare, wouldn't the number of taxpayers affected by this supercharged tax increase over time, capturing more than 2% of the taxpayers?
If you don't index the income threshold upon which a tax is applied, over time, the the real value of those thresholds, of course, erode due to inflation. So we've had bracket creep in the past in our tax system, and sometimes it's sustainable and sometimes not, depending on what's going on. There usually is eventually some pushback on it.
President Biden's Medicare proposal and President Obama's Affordable Care Act both doubled counted Medicare revenue. So, Mr. Capretta, these are obviously underhanded gimmicks in the budget. How does this impact federal deficits and debt?
Well, I do think this is an underreported phenomenon, which is when you include on the PAYGO scorecard Medicare savings and HI in particular, you can end up double counting it. It can make the solvency of Medicare improve, which allows higher payments for Medicare down the road, and it also could be used to finance another bill, through the PAYGO scorecard. So I think what we should try to avoid when we're working on Medicare solvency is taking credit for it on both sides of the budget. Especially, a lot of times it's not big enough to make a real big difference, but Medicare's big. And so when you put a lot more money into Medicare and then also claim you can spend it under PAYGO for something else, that's when you end up with a problem.
Thank you, Mr. Chairman.
Thank you, Senator Grassley. Senator Padilla, followed by Senator Johnson.
Thank you, Mr. Chair. Just want to remind us that during last week's hearing, several of our colleagues discussed the impact of the American Rescue Plan's expanded child tax credit. It was nothing short of striking that the national child poverty rate hit a record low of 5.2% in 2021. That included a decline in the rate of Hispanic children from 14.7% in 2020 to 8.4% in 2021. That's something I think we're all proud of, both sides of the aisle. Recent census data shows, however, that many of these families slid back into poverty upon the expiration of the expanded child tax credit. Now, I can't help but notice that a lot of the Republican proposals for spending suggest delaying or reducing benefits that have been earned and are meant to be retirement security for older Americans. The poverty rate amongst U.S. seniors 65 and older is already nearly double that of the OECD average, and just 3 countries have worse income inequality among this age group. Question for Dr. Moon. What are the expected impacts of these proposals to cut Medicare on senior poverty rates and inequality?
Thank you. I think that the important thing to keep in mind here is that older and disabled Americans are like all the rest of the population, and that is there are some who have very modest incomes and some who have much more substantial incomes. But the number of seniors who rely upon Medicare and Social Security to a massive degree is much higher than many people appreciate. And for those with moderate incomes and not very far above the poverty level, because our low income protections for seniors are not that generous, this is a real potential burden. They're already paying a substantial amount, often more than a quarter of their incomes for their health care costs, for example, and further cuts in the Medicare program or further requirements for them to pay more would have a substantial impact. It doesn't always show up in terms of the formal poverty rates because we base that on income and not on Medicare, but people who look at the in-kind contributions that are made in alternative measures often note with alarm what would happen if you were to, for example, reduce spending on Medicare.
Thank you. Now, unsurprisingly, a lot of our Republican colleagues are focusing on cuts across the board in the budget, and Medicare is no different, focusing on cuts to benefits, cuts to coverage, and cuts to access. When I believe what we should be discussing is ways to preserve and build on Medicare's many successes. Now, efforts to strengthen Medicare and save on costs don't have to be mutually exclusive. For example, the collaborative care models is an evidence-based and cost-effective strategy for treating common behavioral health problems in primary care that remains underutilized. About 1 in 4 Medicare beneficiaries live with mental illness. I mean, that's the population at large. But only 40 to 50% receive treatment. It's also more pervasive in beneficiaries from American Indian, Alaska Native, and Hispanic communities. Now, the President's fiscal year 24 budget laid out a plan to extend the life of the Medicare Trust Fund while also lowering costs for mental health services. And specifically, it eliminated cost sharing for some mental and behavioral health visits and required parity between physical health and mental health coverage under Medicare. We knew mental health was a crisis before the pandemic. It's only been exacerbated and spotlighted by the pandemic. And since, Dr. Moon, how have these cost-cutting debates influenced the scope of Medicare coverage, including for mental health services?
I think that mental health is a good example, like a number of other benefits that have often been underappreciated. Home health was one of them for a long time. Hospice care is another example. And often in a zeal to cut costs, the notion is if we expand the services that are offered, they will suddenly be abused and costs will go up, rather than thinking about what the appropriate way to provide care is. I think that reforms that are aimed at improving the quality of care by making it the right care at the right time always makes sense and should always be an effort. And I think mental health would be one of those things. What you want to be very careful about is not doing, assuming that there are cost cutting that's less careful in terms of protecting the things that need to be protected.
So, thank you. And if I heard you, let me sort of rephrase for the folks back home, just as with physical health, treating mental health in emergency room settings is not the most cost-effective approach.
I totally agree with that.
Thank you, Mr. Chair.
Thank you, Senator Padilla. Senator Johnson.
Thank you, Mr. Chairman. Had I not read my schedule, I would have thought maybe this hearing would have been titled Our Broken Tax System, which, by the way, anytime we have the chairman of the Finance Committee, anytime you two want to sit down and work to simplify and rationalize our horribly complex and broken tax system, I'm all in. But this is a hearing on Medicare, and unfortunately, I think the chairman and so many Democrats are pretty much one-trick ponies. Whether it's Social Security, whether it's Medicare, the only solution is increasing taxes, which, again, I don't think we ever generate the revenue by increasing taxes because it harms economic growth. From my standpoint, if you're looking at how to fix Medicare, you've got to look at the root cause of the problem. And I would argue the root cause of the problem is the cost of health care. Why is it so grossly expensive and out of whack with other nations? There are many reasons, but I would argue we have largely removed the benefit of free market competition out of health care across the board. And again, I come from the private sector. I didn't like competition. I would love to have been a monopolist because I had to compete. My prices were a lot lower. My quality was a lot higher, as well as my level of customer service was a lot higher. That's what a functioning free market system does. Unfortunately, in health care, only about 10 cents of every dollar is paid by the patient, and 90 cents is paid by somebody else. And so we have no idea what anything costs. There's really no consumerism involved. There's not consumers making wise choices and calculating what something costs versus what the benefit is. So, Mr. Capretta, you did, in your testimony, mention three forms of competition. You said choice, you talked about premium competition, you talked about provider competition. I mean, would you basically agree with my assessment there that the root cause of this is we need to interject the benefits of a competitive marketplace into healthcare? And that's what we ought to be talking about here.
The answer is yes, but it's complicated, as you know, which is why it hasn't been done. In healthcare, I think it's important to understand there has to be some structure. There are some market failures in healthcare. I wrote a book recently. I'll make a plug for it, U.S. Health Policy and Market Reforms, an introduction. Kind of covers the, as an introductory matter, sort of different things that need to be done to bring more discipline from the marketplace into the health system. It can't be done, though, just by deregulation on its own. It has to be structured so that the person who's making a choice can see very clearly a price difference based on the same insurance plan or the same medical service. So that means in the insurance context, standardization of the benefits so that the premium difference is very clear.
Let me quickly interject. I think also you need to separate healthcare costs in terms of the catastrophic costs that need insurance and the non-catastrophic that people could pay for out of their pocket. I think, if we could separate that in some way, shape, or form, as opposed to paying for everything. I have limited time. I also want to talk about figure one. You talked about the fiscal challenge. I would call it a fiscal crisis. It's a slow-moving train running right at us, and Washington, D.C. is not addressing it. We're, as you said, about a $2 trillion deficit this year. We're spending $1.9 trillion more this year than we did just 4 years ago. And your figure one is pretty stark, showing that about half of Medicare costs are going to be provided by the general revenue fund. That we're going to have the same problem with Social Security when the trust fund runs out. If we're going to plus out those benefits, we're going to need revenue out of the general fund. And the question I have is, will we have the financial wherewithal to plus up those benefits, to meet the requirements of what Medicare is going to need in terms of financing? And that starts to speak to prioritization of spending. We've used this committee for climate change and the budget. Talking about, by the way, in testimony, over $5 trillion has been spent globally combating climate change. I would argue it obviously hasn't made a dent because we still have climate change alarmists. $5 trillion. We're in the Inflation Reduction Act, another $1.2 trillion, according to Goldman Sachs study, is what is going to be spent because of that piece of legislation. We need to start prioritizing what limited resources we have to the priorities of government. And again, I would say Social Security and Medicare, those promises we made to seniors would be top priorities, and maybe these green energy boondoggles that are not going to fix climate change would probably be a lower priority for spending. Would you like to comment on that?
No, I don't think so. I'm not an expert in the...
Okay, set aside climate change, just in terms of we need to get our arms around these massive deficits, this massive debt, or we're not going to have the financial wherewithal. We'll have a debt crisis, and then this all comes crashing down, correct?
I do think we are headed towards some major dislocation if we don't get fiscal discipline into our budget process. So I would very much recommend, on a bipartisan basis, that both sides get together and start working through some of the challenges of getting the debt down, deficits down, so we don't pile up as much as we're projected to in the coming decade and certainly over the coming 30 years. It's really a very big problem, and it's going to require both taxes and spending.
But also prioritization of spending. Okay, thank you, Mr. Capretta. Thank you, Mr. Chairman.
Thank you, Senator Johnson. Now we turn to the distinguished chairman of the Finance Committee, who has spent more time fighting for seniors than I think almost anybody in Congress, going back to his early Gray Panther days in Oregon.
When I had a full head of hair and rugged good looks. Thank you, Mr. Chairman, and good to be working with my colleagues, see a number of members from the Finance Committee. Colleagues, the fact is the ultra-wealthy can fire off a text to their accountant and say, make sure I don't pay income or payroll taxes this year. And they go on and say, what kind of tax workarounds can you get me so I don't have to pay those taxes? And the fact that these schemes are legal, underline legal, highlights the fact that if the ultra-wealthy paid their fair share of taxes, there wouldn't be such a serious Medicare shortfall. And you contrast what I just described, which can happen every day, be legal, to older Americans who worked hard all their lives, paid their fair share of taxes year in and year out, didn't have accountants who'd get them this special deal. And those older Americans are now staring down the barrel of a serious Medicare shortfall uncertainty. And I'm all in, colleagues, on transformational Medicare reform. Before he retired, Chairman Orrin Hatch of our committee and I joined in a landmark kind of reform that I'm going to ask you about in a minute, Ms. Moon. But I want to start with a question on the revenue side. I proposed, colleagues, as chairman of the Finance Committee, a menu of ideas for colleagues to choose from. A menu, not I'm going to require you do this and this. The menu includes wealthy partnerships paying their fair share. Back when I was coming up, partnership were a couple people who ran a sporting goods operation. That's not these big partnerships now. The billionaires paying their fair share, closing the self-employment, loophole and more. This seems fair to me, and it sure will strike the millions of working Americans who pay taxes day in and day out. Those taxes are collected on them, and they don't have all these breaks. Ms. Wong, what do you think? What are your thoughts with respect to something that's fair and, by the way, gives everybody in America the chance to be successful? We want people to be successful. We just want everybody to do it. Your thoughts?
Completely agree that there's a wide menu of really economically sound ways to broaden the tax base, and we have our own, you have yours, there's a lot to choose from there. But let's start with the one where if I were to get the text message from my multi-billionaire client about how I can, spend all I want this year without paying any taxes, well, the first thing I would do is look at that billionaire's $100 billion worth of stock and say, well, why don't you just take out a credit line against that stock? You can borrow $10 billion, put that stock up as collateral, spend it on whatever you want, and you won't be facing any capital gains tax or income tax on that. So that's income that doesn't ever see the tax system or the tax returns in the year that it's made or in the year that it's spent. And that's one of the biggest holes and one of the first places I would be looking to make the tax system fairer.
Okay. As you know, our theory is give everybody in America a chance to get ahead. That's what the menu's all about. Now let's go to transformational change, Ms. Moon, and thanks for all your good work. Before he retired, the late Orrin Hatch and I said, Medicare today is not the Medicare we had when we were coming up. It's mostly about chronic illness, cancer, diabetes, heart disease, strokes, and not just acute care. And a very large percentage of seniors has 2 or more of these conditions. So Chairman Hatch and I wrote what I think is a transformational update of the Medicare guarantee. It's not a voucher, it's a guarantee. But we'll use reforms like telemedicine. We'll use simple preventive steps. Colleagues, you want to help seniors? Let's get grab bars in showers. Costs a few dollars. Seniors save untold injuries and costs. Those are the kinds of reforms that make sense, that update the Medicare guarantee. So we've talked about revenue. Ms. Moon, you've been one of our leading authorities. Chronic illness is what Medicare today is all about. It was acute care when I was coming up. Your thoughts?
I think you're absolutely right, and the Medicare program has not changed with the times in that way. It's changed in a number of ways that have improved, but I think part of the problem has been that when new ideas come along, the fear is you're just going to add that on and it's going to be another add-on to the costs, and so there's a reluctance to do it. On the other hand, one way that people often talk about is, well, then let's turn it over to the private sector and just give them an amount of money and let them decide. That solution hasn't worked very well either, because we have not had the kinds of oversight and controls. There are very good Medicare Advantage plans out there, for example, that serve the needs of the people that they function for. But there are others that are in it just for making money as good insurers, and I can tell them exactly how to do it, and they know how to do it very well, and they're very successful at it, but it hasn't necessarily improved our healthcare system.
I'm glad you made that point, because not all Medicare Advantage plans are created equal. And I think you know the Senate Finance Committee, and we've had a number of colleagues here, has been leading the fight to crack down on those abuses. I know my time's expired, but thank you for the kind words about the new focus on chronic illness, because I think dollar for dollar, with some very small investments in prevention, we can get big savings. Thank you. Thank you, Mr. Chairman.
Thank you. Next is Senator Scott, but before his clock starts, I just wanted to add 30 seconds of chairman time to point out that things like grab bars in showers are the very kind of things that doctors in ACOs are able to arrange for their patients because it makes sense and creates savings when they install those kind of things. We have had our doctors in Rhode Island who do this, do things as simple as make sure rugs are non-slip in people's houses in order to save money for the system, keep people healthier, and do their work better. So with that observation, let me turn it over to Senator Scott.
Thank you, Chairman. You know, it's interesting that Senator Wyden brought up the idea that there's rich that take advantage of the system. Joe Biden and his wife actually did that. They took money from income that they should have paid Medicare tax on. They put it into an S corporation so they could take money that they were from paid speeches and books, put in there so they didn't pay the 3.8% Medicare tax under the Affordable Care Act. And that's something that clearly ought to be fixed because it's clearly unfair that people are doing that. I think it's very important to every state, but clearly my state, that we don't see a reduction in benefits for Social Security and Medicare. So I have a bill that would stop that. Unfortunately, I haven't had the opportunity to get Senator Schumer to put on the floor. But it would be, I think none of us should be supporting it. And there's lots of ways to reduce the cost of delivery of health care. But one thing we shouldn't be doing is ever talking about doing anything to reduce the benefits of Medicare and Social Security. And I know Senator Johnson brought this up. If we don't get this budget under control, how is interest expense going to come down? So, Mr. Capardo, what do you think? Do you think if we continue to run $2 trillion a year deficits, the interest costs for not just for the federal debt, but for buying a house? Mortgages are now up to almost 8% for a 30-year mortgage. Car interest rates are up to a 23-year high. I think credit card might be the highest ever. So if we don't get the budget in control, is our interest expenses going to come down?
No. According to CBO's current projections, by 2050, the net interest payment on the accumulated debt would be 9.4% of GDP, which essentially means, every dollar that comes in, half of what we're raising in revenue would basically be going toward net interest payments under current projections. So that's too much, obviously. And so well before 2050, we're going to need some action by Congress, I think, to kind of do both the revenue side and the spending side.
And is Medicare dependent? Medicare paying for Medicare dependent on what how much money we have in revenues? So if we're going to spend it on interest expense, we're going to have less money to put into Medicare?
Well, actually, it doesn't quite work that way. I mean, the way the Medicare Trust Fund, HI Trust Fund works is, at least in theory, if it ran through its reserves, the spending is going to be cut across the board probably. So that's one reason why this is such a big issue and exhaustion of the trust fund is a concern. Now, a lot of people think, well, that would never happen. Congress would step in and say, well, we're going to pay the benefits anyway and borrow the money. So in some sense, what CBO is projecting is we're just going to end up paying the Medicare benefits one way or another and have to borrow it from somewhere. And I think that's the cycle that we're in that needs to be thought through about how to get out of it.
So there's been a lot of proposals by Democrats to raise taxes to pay for Social Security and Medicare in particular. So right now under parts B and D, do the rich get subsidies? Are there payments subsidized? So like right now, if you make say $500,000 a year, do you pay the full cost for part B and part D?
Not yet. They are starting to pay income-related premiums, but they don't cover the full cost of the program yet. So no, they still get some subsidy. And that's in part because the people who wrote that provision wanted to make sure there's still large participation, even amongst, it's supposed to be a universal program, at least in theory, that everybody participates in, higher income and lower income. And so that's the theory behind giving at least some subsidy for B and D to the high income.
But just put in perspective, they are subsidized.
Yes.
Okay. So So if we, do you know how many taxpayers make more than $500,000 a year? Like if you're gonna tax the wealthy, I assume that'd be over $500,000 a year. I don't know, maybe it's 200,000. How many taxpayers are there?
Well, you might want to direct that to our tax expert here. I'm not sure I have that number at the top of my head, but it's going to be a small number relative to the
How many taxpayers make more than $500,000 a year?
Well less than 2%.
Say
Oh,
again?
sorry, did you say? Well less than 2%.
So what's the number? So that how many make less? Be less than 2 million, right?
If somebody's got a calculator on them,
Yeah, it's less-
300 odd
it's less
million
than 2 million.
people, 2.5 people per household,
Okay.
2% of that.
Okay, so it's less than 2 million. How much should their taxes go up? And what are they paying now? What's the average person that makes $500,000 a year or more pays? What are they paying now in taxes? And what should it go up to make sure that, there's never a cut in any program?
Yeah, so, I mean, like, if you want to look at an even smaller slice, the top 1%, say, they get about 21% of all of the income in the nation, and they pay about 24% of all the taxes. That's federal, state, and local, and all types of federal taxes. The one thing that is a little bit somewhat misleading about that statistic is that included in their income is not all of the gains on the very large growth of their assets. So when you take into account that kind of income, and if you look at an even smaller slice of people, they only pay about 8% of their incomes in tax.
But when they sell it, they pay taxes.
Yes, but the problem is that they don't have to sell it, and they can hold it over their lifetimes or even
What would you
generations.
take it up to? What rate would you take it up to?
I think that there's a long way to go from something like 8% to either the marginal or even the average rates that most ordinary filers face. So if you look at the middle of the income distribution, they
But
pay about...
what would it take to make sure we don't have a deficit?
to make
We're
sure-
getting well into Senator Van Hollen's time, if you could wrap it up.
Now, I just want to ask her, what number would have to go up to?
Well, if we were to just say reverse the total deficit impact of the Trump and Bush tax cuts,
And that would
be
we'd have a balanced budget?
about 3% of GDP. That would be enough to completely wipe out the increase in the debt to GDP ratio over the long term.
We would have a
Senator Van
balanced budget.
Hollen.
Thank you, Mr. Chairman. Thank all of you for your testimony. Mr. Capretta, I think in your testimony you acknowledged that in order to address the Medicare shortfall, there needs to be a revenue component, and I heard you say that you would support closing some of the tax loopholes. Would that include closing what is known as the Gingrich-Edwards loophole?
I don't know what that is, so I can't comment.
That's the loophole where people manipulate the amount of their income that comes in wages versus in business income to lower their Medicare tax.
Yes, I'm not against that in theory. I think that might be best handled and put into our income tax side. Medicare, going back to the history of it, we added a new payroll tax for Medicare in 1965, in a sense being a contribution from working wages that paid for their hospital coverage and retirement. I'm not adverse to changing that kind of original deal. Yeah. But I think we should be cognizant that we are going to change it. If we start introducing very different tax bases.
If I may, just because my time is short, we're talking about closing a loophole that allows people to manipulate what part of their income is wage income, and therefore the Medicare tax applies. But no, I do appreciate the fact that you recognize and support that we need a revenue component, that we need to close loopholes. I wish that was a bipartisan conclusion right here in the Senate. I would welcome any of my Senate Republican colleagues joining me today to introduce a bill to begin to close these loopholes to help address the Medicare trust fund issue. And I do want to applaud the chairman of this committee, Senator Whitehouse, for the bill that he introduced. I'm proud to co-sponsor that bill. But at least it puts a plan on the table. You know, our colleagues can agree or disagree with it. They disagree with it, apparently. But I've just been looking at what the House Budget Committee passed this last week with respect to Medicare. And here's what they said. We're going to get $400 billion in savings over the next 10 years through, quote, bipartisan solutions. In other words, they just totally kicked the can down the road. They refused to put a plan on the table, as Senator Whitehouse, myself, and others have put a plan on the table. And so there's a big difference between, complaining about the Democratic plan and actually putting a Republican plan to deal with the Medicare solvency issue on the table. Now, I do applaud the Republican study group for at least putting a plan on the table. Dr. Moon, that plan is going back to the idea of voucherizing Medicare. I recall when Paul Ryan was the chairman of the Budget Committee, he put forward a plan. I disagreed with it, but I credit him and his colleagues with at least putting forward an idea. There's no idea right now, apparently, in terms of the Republican Budget Committee, and I haven't seen a plan from my colleague. Could you talk about what voucherizing Medicare would mean to seniors?
I think if you're using it as a means for holding down spending, it's pretty clear that what you're doing is kicking the can down to the providers or insurers who are going to get those funds and have to make them stretch to provide the Medicare benefits. And that's a difficult thing because we have not seen incredible creativity on the part of such individuals, particularly insurance companies, of finding ways to hold down costs aside from doing things like denying care and raising premiums. There are ways in which you can improve efficiencies and you can be creative, but those are much harder to do and much less likely to be put in place by somebody who simply wants a quick buck from the payment that they're going to get. And that's what has tended to happen in some of the poorly operating Medicare Advantage plans. And I think that's a prescription for what would happen under the voucherizing of the program. I think ultimately it has to be a responsibility between providers of services and the government to try to figure out how to find ways to be more creative and efficient in the healthcare system. Just giving it over to someone and saying it's your problem now, I don't think will solve the problem.
I appreciate it. And Ms. Wong, if I could just get a very short answer to you on a question, because I think you've mentioned this, but I just want to make sure I understand. Many of us are trying to make sure the IRS has the resources it needs to crack down on very wealthy taxpayers who are not paying current taxes that are due and owing. And I think you've indicated that about $100 billion each year that would go into the Medicare Trust Fund as well as to Social Security and an unemployment trust fund, $100 billion a year in what's due is not being collected because the IRS does not have the expertise at this point in time to do that.
That's exactly right. And, if you have a service that has lost 40% of its expert auditors and it can't get staplers and pens for some of its sites, that's going to happen. And that's why cutting IRS appropriations and mandatory funding will hurt deficits, will hurt the funds, and will also hurt filers that want the IRS to pick up the phone.
Right. So, Mr. Chairman, just in closing, I would point out that while the House Republican budget doesn't put forward any plan on Medicare, the fact that they want to turn back the resources for the IRS would actually make the situation worse. Thank you.
Senator Braun.
Thank you, Mr. Chairman. I'd like to point out, because the comment was made earlier about the Trump tax cuts, whether you calculate that at $2 trillion or $1.5 trillion, that is either $150 billion over each year for 10 years. I want to point that out, or $200 billion. And I'd also like to point out that our deficit is now $2 trillion a year. So complaining about that is such a small part of the total deficit that we're living with that is now amounting to $1 trillion every 6 months. Medicare, Social Security are the drivers of it, so we need to do something if we're going to save them. We never talk about, on Social Security, that's fairly easy. You get 3 or 4 variables. do we have the political will to do it if we want to save the system for those that are going to be retiring down the road? I don't think anybody's worried about the fact that we'll borrow enough money to backfill to get folks nearing retirement or in it. Never hear about the underlying cause of healthcare costs because of the industry itself. In my own business, I created consumer involvement and transparency for them to work with, and we were able to put a big dent in it. Of course, that's skin in the game. Nobody wants skin in the game anymore. They either want the employer to pay for their health care costs or the government, and that was not that big a deal 30, 40 years ago when it was under 10% of our GDP. Now it's approaching 20% of our GDP. I'd like each one of you to comment on anything we do with taxation. That is a political endeavor that no one wants to take on. Even when the other side of the aisle, I've had the argument with Senator Van Hollen, we've never been able to generate much more than 18% of our GDP in tax revenue. Raise the rates, you get a little more into the Treasury, your economic growth goes down. So it is doable if we take on the healthcare industry to make them transparent, competitive. That's big hospitals, insurance. Try to get it to where it does what most other industries do. Is that even something that anybody thinks about? You could get probably 10 Republicans interested with maybe all Democrats if it was based on competition and transparency. It would make the cost for government as the payor to come down. And I know it works because it's worked on things like LASIK surgery. It's worked on enterprising private health insurance plans that keep their employees safe from catastrophic risk through injury or illness. Did it in my own company. 15 years ago, we haven't had a premium increase in 15 years. Just using the user or demand side of the equation. I'd like each of you with a minute and a half, just tell me, is that doable? Do you ever think about it? And why wouldn't that be part of the solution that would help all health care, whether it's Medicare, Medicaid, or through private insurance? Start here.
I'll be very quick. The answer is yes. I think a lot can be done in this area. As I said to Senator Johnson earlier, we need to put some structure around the choices, some standardization, and make it absolutely clear to the consumer when they can save some money and when they would benefit. So you got to standardize what they're pricing in the medical services market, not insurance, and you got to standardize insurance too, so they can see clearly the premium difference. Right now, it's very obscured and complex, and you got to take a lot of the risk out for the patient. It's all got to be win-win for them. Pick a less expensive option, they save money.
Sounds like an excellent plan. The remaining two witnesses, the other side of the aisle, generally looks for more revenue. I've not found an easy way in my nearly 5 years here to get any new revenue that is going to meet the agreement of 60 senators, or you have to do it through reconciliation. What about reforming the industry? Is that something you'd be interested in?
Well, I think I'm still an optimist, and I actually saw a little bit of cross-partisan agreement around closing a big loophole that affects the Medicare taxes today, and that would save around $300 billion over 10 years. And I also
That's
think,
only $30 million a year.
and I think that there is
And that's a Band-Aid. Your big issue is your 20% of the GDP currently. So go ahead.
Well, I think that base broadening is one of the areas where members of both parties have looked to over time, in part because a lot of that you can think of as spending that goes through the tax code, and some of it is very inefficient and ineffective at what it does, and there are very many responsible ways of raising revenues through that approach.
I think that we should always be looking for ways to make the program more efficient, to work better, to meet the needs of patients. And I think some of what Dr. Capretta had to say makes a lot of sense. But I would also add the caveat and caution that people, when they are faced with very high medical expenses, which is where most of the costs of healthcare come from, aren't good at making choices. You're in a crisis, you're trying to figure out what you're going to get, and we have a very complicated healthcare system that does not work well to provide either information to people or to help them make
I think
choices.
you've just made my case right there. So we're running out of time. I like what you're saying because that is true. I would offer that if we're going to do anything in the near term, it's going to be difficult to raise revenues. We've already done some stuff in our HELP committee to where taking on reforming the healthcare industry. Remember, the providers are going to still be there. The government either pays for it or employers do. You make them more competitive. You get rid of the barriers to entry. You harness entrepreneurialism. That's the only way you take it from being 20% of our GDP down closer to what most other countries get it at, which is 12 to 13%. There's room, I think, for bipartisan maneuvering there.
And I think, Senator Braun, you have a track record of accomplishing just that. So I do look forward to working with you. Senator Kaine is walking in as his time comes. Would you like a moment to get yourself
Mr. Chair, if
oriented
anyone
before
else hasn't
recognized,
asked questions, I would
ready to
rather that
roll?
they go before me, or has
Well,
everyone
Senator
asked?
Johnson has already had his round, but he's been waiting patiently for a second round. So I'd be more than happy to give him 5 minutes and then turn to you.
That would be
and we'll
great.
wrap. Let's do that.
Well, really, just
Get
to
an
make,
extra round, Senator Johnson.
I appreciate that. So just to make the point, Senator Brown was talking about revenue percentages and spending percentages. Year 2000, total spending was 17.7% of GDP, according to Mr. Capretta's Table 2. Revenue was 20%, so we had a surplus. This year, 2022, revenue is 19.6%. Those are pretty historic highs. As Senator Brown, generally we're somewhere between 17 and 18%. So we're historically high. By the way, and that 17%, 18% is regardless of what the maximum tax rate is. I mean, we've had tax rates in excess of 70%, and you're still raising about 17, 18%. Because, again, we have such a broken and complex tax system, all kinds of loopholes. The government can only collect X percent, and kind of 20% is sort of the top level right there. But the difference this year is spending is 25.1%. So again, when we had a surplus, spending was 17.7%. Now that we have massive deficits, spending is up to 25.1%, which brought me to the conclusion that we better start prioritizing spending. We just can't continue to spend a quarter of our GDP through the federal government because we'll never be able to raise the revenue. No matter what you do, you just can't get 25%. You can't squeeze that out of the American taxpayer. So we better recognize that reality. And again, I would point out that the solution is what Senator Brown was talking about is how do you reform the healthcare system, and as I was talking about, to reintroduce consumerism. And I'll say, separate out the two different types of spending. And I wouldn't mind Mr. Capretta talking a little bit more about that. Medical services. I mean, the routine care that we all go in, that, for example, Medicare. We got a waiver during COVID for telehealth that then expires, and all the medical providers in Wisconsin are saying, can you extend that exemption? Because telehealth worked really well. Well, why would they even need an exemption? Because it's government run, it's bureaucratic, and makes no sense. So when you have government regulation, government bureaucracy, it just prevents providers from being imaginative, showing some real progress in terms of how to deliver things more efficiently. Again, what this free market does. Best possible price, best quality, best level of customer service. Again, that's what the free market does. Why don't we introduce more of that? Ms. Capretta, just real quick, would you like to respond to that?
Yeah, I think we're on the cusp of maybe doing some of that with the price transparency requirements that have been put in place. Some of it might be statutory if the Congress moves ahead. But there needs to be more standardization of packaged benefits. And by the way, I would agree with the comment that not all of healthcare is going to be subject to consumer discretion. There are a lot of studies of this, and it's going to be probably about 40%. So there's some big ticket items where you can't shop.
Okay, so real quick.
But there are some things where you can.
You're saying about 40% would be kind of what you earlier referred to as medical services.
Yes.
And then 60% would be, again, the catastrophic care, the things you need insurance for.
Yes.
Correct?
Correct. It'd be big things where it's not really a packaged, discernible item. It's going to be some ongoing event with unknown outcomes. And so you're going to spend a lot of money, and you can't really shop for it.
Look, you mentioned transparency. I know there's a lot of talk about that. Again, you introduce free market competition, you automatically get transparency because consumers are asking, what does it cost? My concern about government-regulated transparency, it'll be fudged. I mean, it's just not going to work as efficiently as a free market system that just demands price transparency. And that's nobody knows what anything costs in healthcare. I mean, nobody knows.
The only point I would make there, Senator, on the other side is that when a consumer wants to buy a surgery, for instance, they need to have the surgeon in, the anesthesiologist, the radiologist, the diagnostics.
Yeah, but
they need a packed benefit that they can figure out and price.
That's the insurance side of the market. That's the insurance side. You know, the example I use is eye care. You know, people do pay for that out of pocket. So, you know, LASIK surgery has dramatically come down in price because consumers know what it costs. They understand the benefit. If we get more of healthcare in that model, and then look at the insurance model, and again, pre-package it, have it very standardized. When I was in business, it drove me nuts buying insurance because you always had to look at, well, what does this plan exempt? It made no sense. I mean, they just exempted certain conditions to save money. So there wasn't transparency in that insurance, and that's where I would definitely go toward specific models. This, you know, coverage A covers all these things. Coverage B covers this, and have that standardized. That you would require government regulation.
I'm very much for that, yes.
Okay, good. Well,
With
there
that,
we got some solutions here, Mr. Chairman.
With that, we turn to the patient, Senator Kane.
Not patient. I needed to adjust my brain into the right committee. So thank you, Senator Johnson and Mr. Chair. A recent New York Times article caught my attention. The article was entitled, "A Huge Threat to the U.S. Budget Has Receded and No One is Sure Why." I'd like to introduce that New York Times article for the record, Mr. Chair. The article outlines that since 2010, Medicare spending has been significantly lower than expected. According to the CBO, between 2010 and 2020, that cost was about 9% lower than what they had expected. And the most interesting part is that nobody's 100% sure why. Is it a combination of legislative changes, new laws, economic changes, technical changes, which CBO estimated led to some past overestimation of spending per beneficiary? And the majority of the decrease has come in this category, less spending per beneficiary. I'd like to understand a little bit more about this. I wonder whether the passage of the Affordable Care Act and the extension of health insurance to working Americans in the millions who had never had insurance before might have led them to live healthier and thus need less health care immediately upon obtaining Medicare eligibility age. But Dr. Moon, might you speak to that trend and offer any thoughts that you have about why Medicare spending over the last decade was lower than expected?
Sure. I agree that we don't know exactly, and it's very hard to parse it out. But we do know, for example, from studies that have been done of people who come onto the Medicare program when they did not have insurance before they came on, they spent much more in the first few years, and it lasted for a number of years than other beneficiaries who had insurance. So undoubtedly, the Affordable Care Act will have had a very large impact, and I think there'll be eventually studies that show some of that. The other thing that people don't focus on so much is that that also is a period of time when the baby boom generation was first becoming eligible for Medicare, and 65-year-olds are much cheaper to provide care for than 85-year-olds. And when we baby boomers, I as one, get a little older, we'll be adding to the cost. So some of that may not stick. I think we're also finding some ways in which people are a little more skeptical and concerned about their care and asking better questions. Some of that, as people were talking about competition, some of that may help. But I'm also a skeptic that we have a system that's very receptive to people making good choices. Mm-hmm. This is really important stuff to people. They don't want to mess around. They're not going to go out and shop 14 different MRIs before they choose which one they're going to get, et cetera. We're going to have a real difficulty wrestling this to the ground, and I think this is going to have to take concerted effort of more consumer information, better investment in providing that information to people so they can make good choices, but also better government controls and insight into how we manage this very cumbersome but important system.
Well, there is an overlap in your comment and what Senator Johnson was saying. A market where people don't know what the costs are or shopping for the price of 14 different MRIs to decide which one to take is not the way people will approach their healthcare choices. We've got to figure out a way, more information, more transparency. I think all can agree on that. Ms. Wong, I want to ask you a question. Your testimony describes how the wealthy can often structure their affairs to choose their tax rates and when, even if ever, their income is taxed. I'm a co-sponsor of a bill by Senator Baldwin. It's called the Carried Interest Fairness Act, and that would address this issue, at least with respect to closing the carried interest loophole. Could you describe how reforms in this space could help address the two-tier tax system that you described?
Thank you, Senator. It's a really great example of how preferences in the tax system sort of attract avoidance and sometimes even evasion in complex ways. So the carried interest loophole, as you know, is how some hedge fund managers can choose capital gains treatment on compensation that should really be taxed as salaries. In other words, they can just elect to have a lot of their income taxed at a lower rate. So closing this loophole would just mean that the labour of fund managers would be taxed similarly to workers who are employed at the same companies that these hedge fund managers are investing in. And the 2017 tax law did take a small step towards addressing this issue, but bills like yours and others would more comprehensively close the loophole.
I'm very much a believer that we ought to move to a system where income is income. I would want it to be progressive with rates that would be higher as income goes up, but a system that would not advantage structuring your income as, capital gains rather than salary, or carried interest rather than salary, or interest rather than dividends. We just give people who have the ability to hire sharp accountants and lawyers the ability to, essentially choose their own tax rate. Most people don't get that deal, and we should move to a system, and that would be more fair. And it would be one way we could also address some issues like the solvency and funding solvency of programs like Medicare, really important. As I yield back, I am really intrigued with this Medicare cost issue. And as you said, Dr. Moon, even though this particular question about ACA expansion and connection of Medicare costs, there may not be enough data yet, there has been significant studies about the Medicare spending per beneficiary of people who had health insurance before they reached Medicare age and those who didn't. And just the healthier you can keep yourself during in life, the healthier you're going to be when you reach Medicare age. And if you don't have access to good health care or health insurance, you're going to have a lot of deferred maintenance on the body when you get to Medicare, and that will drive costs up. And so I think if the past studies hold, I think we would likely see that the expansion of affordable health insurance, both through Medicaid expansion, but also just providing subsidies so that people can buy insurance on the exchange at a lower cost rate, that expansion is going to be a significant factor in the reduction over what we might have expected in Medicare per beneficiary costs. So I look forward to more discussion on that. And with that, Mr. Chair, I yield back.
Thanks, Senator Kaine. Let me thank the witnesses for appearing before the committee today and for the many colleagues who participated. Let me also thank the advocates and the District of Columbia seniors who joined us here in the hearing today. Appreciate very much your presence. I would say that perhaps some faint outlines of progress began to emerge in this hearing. I think we had folks on both sides talk about the need to raise revenues. I would favor doing that by unrigging loopholes that benefit very wealthy people. But certainly the prospect and the need for additional revenue seems to have emerged on both sides of the hearing. The opportunity to save costs in Medicare seems to be also a mutually agreed prospect. I would recommend using the Accountable Care Organization, payment reform, escape from fee-for-service treadmill strategies, but I do think that there are proven cost savings that we can pursue. I would think that we could take advantage of the bipartisan standing ovation at President Biden's State of the Union to lock in an ironclad guarantee as we reform this that there will not be benefit cuts and that no benefit cuts becomes a core guiding principle of our conversations. And then finally, that the purpose of the exercise should be to extend Medicare solvency, and I would recommend that we plan to extend Medicare solvency essentially forever, the way my piece of legislation does. Without objection, I will submit letters for the record from AARP, the American Federation of State, County, Municipal Employees, the National Committee to Preserve Social Security and Medicare, the Alliance for Retired Americans, the Medicare Rights Center, the Rhode Island Alliance for Retired Americans, the Senior Agenda Coalition of Rhode Island, and the Rhode Island Geriatric Education Center at the University of Rhode Island. Questions for the record are due by 12 noon tomorrow, and we will ask witnesses to respond to any questions that we may forward to you within 7 days of receipt. With no further business before the committee, the hearing is adjourned. Thank you all.